Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of 78-year-old female, known case of diabetes, hypertension and CAD, status post CABG, presenting to ER with one episode of tonic-clonic activities of all four limbs followed by confusion. On 10-second assessment, patient was conscious and obeying commands. On primary survey, airway is patent, no secretion, gurgling, hoarseness of voice and stridor. Breathing, maintaining a saturation of 98% at room air with respiratory rate 18 minutes and air entry bilaterally equal. Circulation, BP was 120/80 mmHg with a heart rate of 88 per minute. Peripheral pulsations were bilaterally equal. At this time, 2 large bore IV cannulas were inserted. Disability, GCS was E4, V4, M6. Pupils 2.5 mm equally reactive to light. GRBS was done and was 140 milligrams per deciliter. On exposure, temperatures febrile. Adjuncts of primary survey, we had done an VBG which showed a pH of 7.42, sodium of 133, potassium of 3.6 and lactate of 0.8.
Okay. So this patient you told 10-second assessment. Patient is conscious and obeying commands, right? So in airway you are telling there is no gurgling, secretions, foreign bodies. In what type of patients will you expect that? Or why do you say those things in seizure patients?
Because in seizure there can be secretions.
Yeah, it can be either oral secretion that is pooling or patient can vomit and unable to vomit fully, it can pool up there. But in what type of patients will you see this? Either ongoing seizures or on post-ictal phase. But this patient on 10 seconds itself, you know this patient is conscious and obeying command. So they have come back to normal. That patient will never have a oral secretion as such, because once you regain your consciousness, your gag reflex is intact. You will either spit it out or you will swallow it. But airway compromise is very unlikely in a patient who is after postictal presentation. Okay, during seizures, yes, our airway is one of the primary things we have to take care. We have to look for secretions, even bloody secretion due to tongue bite. Suctioning should be done. Ideally, we should put a bite block. We have bite blocks in ER. Bite blocks can be inserted to the either angle of mandibles so that patient can prevent tongue bites as such, and oral cavity will be kept open. Certain patients will go into significant masseter spasm that their mouth will be shut close, right? Shut close like that. We wouldn't be able to even suction the patient. So that is during seizures. So if you are inserting bite block, that should be inserted at the beginning of seizures. During seizure, there is no point in pushing a bite block because patient will not open his mouth. Okay, but patient is starting seizure, in front of you, you can always put a bite block. So you will have a open oral cavity, you can suction the patient. If this patient presented with active seizures, patient is having masseter spasm, teeth, clenching of teeth is there, you are not able to suctioning, patient is having desaturation, how will you manage?
First, put the patient in the left
lateral position. Why do you do that actually?
We keep one hand below the head so that the secretion, and just head little bent so that the secretions can go out of the mouth.
Okay, so basically to improve the drainage of secretions, but that you can put on right side also, right? What is the importance of being put in left side? Why left lateral position? Why not right lateral?
Airway or
basically mainly
no
because
compromisation of
when we come down, what is the possibility, what are we suspecting? The patient might aspirate. That's what we are concerned about. When we say patient might aspirate, below the trachea, at the carina, the right bronchus is much more in line with the parallel to the tracheal line rather than the left bronchus. Left bronchus deviates off in a much more acute angle rather than the right bronchus. So once the patient aspirates, there is a more possibility of the patient developing right lower lobe pneumonia rather than any other areas because it is much more inline. So we keep the patient on left lateral position to prevent such a easy access of aspiration. But the main important thing is what you told, patient's head should be tilted downwards so that secretions which is collected will be flowing out rather than going in. Okay, so you can keep that. But this patient is having a clenched mouth. There is no opening for secretion to come out or you to suction the secretion out. What else can be done? Is there any other way to suction this patient? First and foremost, this kind of patient, if they are having airway compromise, they will be having desaturation. So you should be preparing for intubation first of all, because desaturation with airway compromise, like gurgling of sound is there, you should suspect airway compromise and plan for intubation. That is there. But in the meantime, you can start oxygen to maintain oxygenation till intubation. Similarly, you can put a nasal airway. If you put a nasal airway, the nasal airway is a rubberized tube, so it extends till oropharynx. Since we are keeping the patient on left lateral position with head down position, the tongue fall is very minimal and nasal airway will be at the level of pharynx. You can insert a normal suctioning tube through the nasal airway to suction the pharyngeal secretion. You can keep giving oxygen because nasal air, your suction tube will not be completely blocking the nasal airway. And since nasal airway is in place, the patient will not have any gag reflex as such. You can just insert the suction tube till the end of nasal airway. Do not put the suction tube deep into the pharynx or into larynx. That will entice the patient to have vomiting. But at the level of nasal airway, that is pharynx, whatever secretion is pooled there, you can try suctioning. You can give oxygen through that. And if you put a nasal airway and give oxygen, the patient will have some amount of continuity of nasal airway rather than the secretion to provide oxygenation. So that part you can do. And then if you suspect this airway obstruction, your next step is always to sedate the patient, paralyze the patient and go for intubation. Okay, then.
Other routine lab investigations were sent on breathing.
That part. Now coming to breathing. This patient, this post-seizure, right? Post-seizure. If at all this patient had like a seizure activity with a lot of secretion and all, what difference are you expecting to see in this patient?
Patient will be tachypneic.
Yes, patient will be tachypneic due to hypoxia. So desaturation and tachypnea is something that you expect. And if you see that, you can expect that patient must have already aspirated. And you can start on prophylactic antibiotics to prevent aspiration pneumonia. Because then you know patient is hypoxic, tachypneic, most probably must have aspirated, isn't it? Fine. Then in circulation part, in this patient, you told in exposure and all and disability, you told hypoglycemia, right? You told GRBS is 140, thereby ruling out hypoglycemia. In circulation, is there anything you want to look? Can any circulatory problems cause seizures?
Hypertension
can cause seizures. Hypertension can also cause, not hypertension as such, but hypertension if the patient has Press syndrome. Acute worsening of hypertension causing Press syndrome, patient can develop seizures. Similarly, hypertension in a seizure patient, we should suspect intracranial hemorrhages or CVAs. So hypertension shows patient might be having a cerebrovascular accident, or if the patient is in multisensorium with very high BP, Press syndrome is another possibility we should suspect and evaluate. Okay, so coming to circulation as such, disability is there. So in disability, what are the things that we will look for to make sure patient is out of postictal state? Or what are the features you can ask whether to see whether patient was in postictal state?
Can ask about the just before the incident. or the things what was happening, where the patient remembers thing, where the patient recognizes the family members.
Yes, confusion. Postictal phase can be due to confusion. Patients may not be always agitated or in coma stage, that our patient can be just be confused. Increased drowsiness. When you make the patient wake up and you talk, patient will talk something, but as soon as the simulation stops, patient goes back to sleep. So increased drowsiness. Then altered behavior. Patient is very conscious, very agitated, maybe violent. Patient is not at all recognizing anyone. So altered behaviors. Patient having any neurological deficits. Post seizure, patient can develop focal or systemic neurological deficits. Patient can have monoplegia, patient can have hemiplegia. That is known as post seizure hemiplegia is known as Todd's paralysis. Todd's paralysis. It's transient. It will improve over time. But focal neurological deficits can be the features of postictal state. And patient in unresponsive state. That's also can be postictal. Fine. So postictal state, when a patient presents, we should be able to assess whether the patient is on postictal state or out of postictal state. Okay.
Then on exposure, temperatures are febrile. Then we had adjuncts of primary survey. We have taken an ABG.
In exposure, any other things you need to look into other than temperature? Why you told temperature?
Hypothermia.
Hypothermia. So what are you suspecting? Hypothermia causing seizures?
No, whether any infections, fever is there.
Fever. Infection causing meningitis. Basically, meningitis causing seizures. If it is a child, it can be febrile status or febrile seizures itself. So that is the importance of fever. So we are basically looking for causating agents for seizures, right? So what else in exposure can you look for? Poisoning. Poison. Intake of poisons can be there. What else? Other than poison, any other intake?
Alcohol.
Toxins. Alcohols, other toxins. So alcoholic smell is very good indicator, isn't it? So patient has had a binge alcohol intoxication. Patient can have seizures. So alcohols, drugs, intakes we can look for. In our countries may not be, but in outside countries and all, when patient presents with seizures, they will look for needle marks, whether IV drug use is there. So drug use need to be looked into. Okay, so exposure will cover all those things. Then, so adjuvants have been done, you have done a VBG. Why VBG in this case? Mainly because our VBG shows something other than airway. Yeah, we get lactate and we get electrolytes. Sodium and lactate is something we get in our blood gas machine. That's why we do it. If this patient was having a lactate of 10, why do you think that lactate is elevated?
It seizures because of acidosis.
Why seizure should cause acidosis or specifically lactic acidosis? Yes. So if not all seizures, but if a seizure was with tonic-clonic movements, there should be muscular activity. So when there is a muscular activity, it's a uncontrolled muscular activity. It's not like we moving a muscles. It's uncontrolled clonic and tonic movements of muscles, which uses a rapid amount of energy and produces lactic acid as byproduct. And since the huge production of lactic acid happens within seconds to minutes, it takes a while for the circulation to wash out the lactate. So initially when patient presents in postictal state or within 1 hour and all, the initial lactate of patient will be very high. You can even have lactate of 12, 13 and all, and with significantly reduced pH. But if the patient had a tonic-clonic seizures, you don't have to worry about that. Within 1 hour, without even fluid therapy, the lactate will fall. If you give fluid therapy also, it will come down, but in a normotensive patient, you really don't have to give fluid just to bring down lactate. You just give it time, blood will wash it out. That's one thing. But acidosis is also important, because if this patient was having sepsis or septic shock, that is causing acidosis. Sepsis and septic shock can cause seizures. So that is another clue. So you should be really knowing whether the lactic acid is purely secondary to tonic-clonic seizures or is there any other ongoing condition. For example, alcoholic ketosis. Patient was on alcoholic binge drinking, alcoholic ketosis, there will be high anion gap metabolic acidosis. Patient will have low pH, low bicarb, lactate may not be elevated, but pH will be low, patient can have seizures, that is alcohol induced. So, acid-base status should be closely monitored. Same patient, just that patient is drowsy now, okay, post seizure happened maybe like 2 hours back. Patient went to post-ictal state, but after that patient is not waking up, patient remained drowsy, okay. Patient is coming to you, you checked GCS is below 10, below 10, 9, below. You checked ABG is showing, or else what in ABG will you be looking for? Sodium levels. One is metabolic encephalopathy causing seizures. So hypoglycemia, hyponatremia, any other electrolyte abnormality that can cause seizures?
Hypomagnesemia,
Hypocalcemia, hypomagnesemia,
hyperphosphatemia.
Yeah, so usually it's all the hypos that cause, but hyper can also, especially hypernatremia, hyperglycemia, hypo and hyperglycemia, hypo and hypernatremia, but usually hypocalcemia, hypomagnesemia, hypophosphatemia. Hypercalcemia usually causes altered behavior, like psychiatric like diseases rather than seizures. Anyhow, you can look for electrolyte abnormality. What else? A post-seizure patient is drowsy. You are taken a ABG. Saturation is 92. So you are taken a ABG. What else is important there? Anything else? Any other scenario in which ABG is useful for a post-seizure drowsy patient? We told hypoglycemias and all, no. Yes, CO2 retention. This patient had seizures and patient went into post-ictal state. Patient might have had significant, but like for post-ictal state is not a well-defined time period. It's very arbitrary. It differs from patient to patient. It can last for 10 minutes to 2 to 3 hours. Okay, not even 3 hours, even more than that. Okay, Tourette palsy and all have documented to been present for more than 8 to 10 hours and all. So if this patient went into a prolonged post-ictal phase, the patient's cerebral activity is significantly depressed in post-ictal state. Patient's respiratory effort might or can be affected. Similarly, patient must have aspirated and aspiration is blocking a larger airway. Patient's respiration might be affected. Patient may not have significant hypoxia because some amount of ventilation is happening. But CO2 elevation, the CO2 retention is something you need to look into. Because if this patient is not a COPD patient, you are getting an arterial ABG with maybe a PCO2 level of 80 or 85, then it's an indication for intubation because you can't put bilevel NIV in a unresponsive patient or a drowsy patient. You can't because it's a contraindication. So you may have to intubate and support ventilation for this patient. So PCO2 retention is another thing. Okay, what else?
In between that, patient through another episode of seizure from the emergency, which lasted for about 1 minute. There were only tonic-clonic movements. So patient was put in the left lateral recumbent position, and then oxygen mask was connected. Patient recovered in almost about 1 minute.
Now, when you say this, when you explain a seizure activity, it's always better if we have seen or if we can, it's always better to say whether it was a generalized episode or if it was a focal episode which spread and became generalized. For example, patient started having seizures involving tonic-clonic movements of right upper limb, lower limb, then it spread to left side, and involving phase. It might happen very fast, like maybe in 5 seconds or 10 seconds it will start. But if you say a patient, when you saw the patient, if you are seeing only one side, then we know where is the foci. It's basically on the opposite side of the cerebrum, isn't it? So we know that is the area which has started, then it has generalized. So whether unilateral or bilateral, continuous or not, is very important here. Now, second thing, tonic-clonic seizures, as you told, that's one of the commonest thing people will recognize. But what other features patient can present with?
Tongue biting can be there.
Yes.
Frothing, frothing can be there. There can be incontinence.
Yes,
urinary
bowel bladder incontinence is a
can be
possibility.
there. Uprolling of the eyes can be there.
Uprolling of eyes can be there. Is the muscular movements only tonic-clonic movements?
No.
What else can happen?
Myoclonic movement.
Myoclonic jerk-like movements can be there. Tonic posturing can be there. Patient may not have clonic movements. Patient will be just in a hyper stiff position in which there is increased tone. Patient will be having generalized hyperflexion position, isn't it? Staring looks can be there, isn't it? Patient can lose tone. Patient might have been doing something, suddenly lost tone and fell backwards. So seizure is something in which you can't control your tone or your posture. Patients usually tend to lose that, isn't it? Now, usually if it is a focal seizure, sensorium may or may not be affected, but sensorium can also be affected in focal seizure. So that is why initially we told the start of seizures. When you say patient was having seizure, if it was focal with altered sensorium or focal then became generalized and with altered behavior or altered sensorium, or it was generalized seizures. If we can identify that, it can help us in localizing the foci of seizures.
Secondary survey, patient known case of diabetic mellitus, hypertension, CAD, status post CABG, presented with one episode of tonic-clonic activity of all four limbs, which lasted for less than 4 minutes. The bystander says that the patient was apparently normal till the afternoon, while when he heard a loud cry from the patient's room, and when the bystander went to the room, he saw the tonic-clonic movements of the four limbs associated with tongue bite and bleeding from the mouth. Following which she was found to be confused. There was no history of facial deviation or upper limb or lower limb weakness. There is no history of fever, headache, no history of any trauma. Past history, no similar history. On CNS examination, power was 5/5 on all limbs. Tone was normal. Cranial nerves were intact. Pupil was normal and bilaterally equal and reactive. Respiratory system, air entry bilaterally equal. Normal vesicular breath sounds. No signs of aspiration. On CVS, S1, S2 heard. Per abdomen soft and non-tender.
Okay. So it was an uneventful examination, right? You didn't get anything in examination, that's fine. But as we were discussing earlier, when we take a negative history, our negative history should reflect the causative agents for seizures. So causative agents for seizure is basically, it can be acute, something that is acutely affecting the brain, either the structure or the metabolic function of the brain, or it can be something due to a chronic condition, or it can be due to something acutely affecting something that is being happening for some time, like acute or chronic condition. These are how causative agents come, right? So acute seizures or acute symptomatic seizures are seizures which is caused by sudden changes in brain structure or brain's metabolic activity. So metabolic activity is very easy for us. We have electrolyte abnormalities, hypoglycemia, hyponatremia, hypocalcemia, hypomagnesemia, hypophosphatemia. This history is also much more easier. We can ask how the patient was. Was the patient active earlier, or was the patient in a deteriorating conscious levels, tiredness? Is the patient on any drugs that can cause these electrolyte abnormalities? For example, if the patient is on diuretics for fluid management, patient can have hyponatremia induced by diuretics, can develop seizures. Similarly, that is one thing. So hypoglycemic, whether the patient was on insulin, previous episodes of hypoglycemia will help in identifying these conditions. That is metabolic. Similarly, it can be hepatic encephalopathy. So whether the patient is a CLD patient, alcohol intake is there, or any previous episode of hepatic encephalopathy, that will help us in identifying whether the patient is having a hepatic encephalopathy related seizure disorder, that is hyperammonemia induced. Similarly, renal failure, whether the patient is on dialysis, missed any dialysis sessions, or having any acute oliguria or anuria conditions, that can cause uremic encephalopathy causing seizures. So these are the metabolic conditions that which is very easily, and the history also we may get. Second thing is structural abnormalities. So structural abnormalities, whatever we have, what trauma. So any recent trauma. So trauma, according to age, we should ask for a prolonged history. Younger the age, very short history. Older the age, a bit more longer history we need to ask about head trauma. It can be due to recent cerebrovascular accidents or ongoing cerebrovascular accidents. We can ask them whether recently any CVA happened, ischemic or hemorrhagic CVA within last maybe 1 week or something, or whether the patient was having any unilateral weakness, hemiplegias or any anglomotor deviation, slurring of speech, to show that patient had seizure during a acute CVA episode. It can be due to hemorrhages, subarachnoid hemorrhages. Then patient may present with severe headache, thunderclap headache, right? So whether patient was having headache with projectile vomiting, then we can think about hemorrhages. It can be due to infection, meningitis or encephalitis. So patient telling histories of persistent headaches, fever, vomiting, then altered behavior, then developing seizure. We can think infection affecting the brain, isn't it? These are some of the structurally affecting conditions we can think about. Then what else can be there? It can be due to toxins and other substances. So either ingestion of substances or toxins, or withdrawal of substances or toxins. Both can cause. For example, alcohol ingestion, acute alcohol intoxication can cause seizures. Similarly, alcohol withdrawal can also cause seizures. So ingestion and withdrawal of toxins. What are the main toxins we are concerned here other than alcohol? Benzodiazepines and barbiturates. Patient can be a long-term benzodiazepine intake patient. For example, patient is a psychiatric patient. Patient was getting midazolam or lorazepam for a chronic months or chronic weeks. Patient stopped it due to unavailability of medicine, or patient didn't take it, or some personal reason. The withdrawal of benzodiazepine will develop seizures. So benzodiazepine, barbiturates, all these things, intake as well as withdrawal can cause seizures. What else? What other intake can develop seizures? Or is there any substances that can precipitate seizure for a high seizure threshold patients? Drugs. What drugs?
Yeah, fluoroquinolones.
Yes. So mainly antibiotics, which is very frequently given, right? So what are the common antibiotics that can? Fluoroquinolones. So fluoroquinolones is commonest. Then
penicillins can cause.
Usually penicillin G, high doses of penicillin G, which is not very commonly used nowadays, but high doses of penicillin G's can cause seizures. Then cefepime can cause seizures. Cefepime, the cephalosporin, cefepime is most common to cause seizures. Then in carbapenems, imipenem can cause seizures. Any anaerobic medication that can cause seizures? Metronidazole can cause seizures. Isoniazid can cause seizures. In TB, in India, if a patient is on ATT presenting with seizure, not only TB encephalitis we should suspect, it can be due to isoniazid induced seizures also. Yeah,
Tramadol.
good. Pain relief, tramadol can cause seizures. Basically, these drugs are not causing seizures. These drugs increase the predisposition for seizures. Correct. So drugs we can think about. Then chronic conditions. something that is chronically happening, that is subacute conditions like trauma, subacute trauma. 3 weeks back, 4 weeks back, patient had a head injury. Patient is having cerebral atrophy that gives time for blood to collect. Chronic trauma. Chronic space occupying lesions. Patient is having a mass lesion which is growing over many months or weeks. Patient was asymptomatic till now. Maybe last couple of days patient started having headache, vomiting or altered behavior, visual changes. Now presents with seizure. So chronic mass occupying lesions. Cerebrovascular diseases, AV malformations, vasculitis. It can be autoimmune conditions, previously not at all detected. Currently patient is having acute seizures. No other, whatever we discussed earlier, none of it is there, but vasculitis is there. So previous episodes of vasculitis, previous history of SLE, APLA, all these are important because it can be autoimmune encephalopathy causing seizures. All these things we can. So these are the history we should ask in our history part to say negative answers, to get negative answers, so we can identify what we are dealing with. Then history wise also, drug history is very important in seizures. More than this, we missed from the patient might already be in a non-case of seizures and might be on anti-seizure medication and patient defaulted that. This is one of the most commonest cause for seizures, defaulting on existing medicines, isn't it? So drug history is very important here. Personal history is important because usage, drug usages, alcohol usages, these comes very important over here. Past history is very important. Patient presents with seizure. Bystander is telling previously he or she had seizure earlier. Then the question will be, is the presentation of seizure similar to the old history or not? If it is similar to old history, most probably it's the same thing. It's a breakthrough seizure. Even though patient is on medicines, patient develops seizures. But if it is a new seizure, we should suspect something new happening inside the brain. That means more imaging, more diagnostic conditions, isn't it? So these are the things we should ask in history as such. Now coming to examination, you have told everything, but we should focus on neurological examination. These patients, when we say there is no neurological examination, they can even have memory deficits. So we have to do a higher mental function evaluation. We have to do a cranial nerve evaluation, because if the patient is having a space occupying lesion, patient may be having a raised ICP, and raised ICP can cause what nerves to be compressed?
3, 4,
3, 4, 6. 3, 4, 6. 3 and 6 basically, right? 3 and 6. So if the patient is having diplopia, difficulty in ocular movements, it's very important. So we'll only understand that if we do the cranial nerve examination. The patient can have a mass lesion in the brainstem, schwannoma, or what is the thing we say for decrease in auditory sensation along with vertigo. I don't know. CP angle tumors. Many of the mass lesions can be there. So examination is very important. Patient may have CV itself. So once the patient is out of ictal phase, we should make the patient do a full power as well as sensory examination as well as cerebellar signs. Maybe patient is having acute CVA features, so that should not be missed into. So examination, these things we have to do. Okay. Now coming to management. What is the important thing in deciding a management of seizure patient? Okay. So yeah, we will split it like that. So this patient comes to you with seizures, right? You had one seizure, even when you are examining the patient itself, you had a seizure. So we'll take that. Patient is actively seizing and presenting to you. How will you manage? First and foremost is positioning. First is positioning. So you position in left lateral position, then
secretions, if anything, suction.
Airway. As we already covered, airway has to be maintained.
Then oxygen.
Oxygenation should be started for breathing and ventilation. Oxygenation should be started, and suction can be given to clear the airways. Okay, then circulation.
Circulation, BP.
You can start some fluids to maintain the circulation if needed. If at all you are feeling the limbs to be very cold, your peripheral pulses you are not getting, you can start some fluids for the patient. Then IV access. You should get 2 IV access, isn't it?
Then initial 5 minutes we should look for the causes where there is any hypoglycemia or metabolic.
No, okay, let's come to that. Initial
15 minutes, no 5.
Okay, so now we comes to seizure management. Till now what we told is supportive management. We are supporting the patient from developing complications due to seizure, but we haven't managed the seizure. Now comes the question, when will you manage the seizure, or do you have to manage the seizure? What is your answers? Should we manage the seizure actively, or should we wait for seizure to settle by itself, terminate by itself? So
wait for
that
the
is
first
a
5
bit.
minutes. Wait for the first 5 minutes whether the seizure is getting settled down or not.
No, so why 5 minutes? What is
If
the
there is
importance
any
of 5 minutes?
correctable causes, we can correct the cause first.
Okay. Okay. No, that's okay. But what I'm saying is, why 5 minutes? What is the importance of 5 minutes?
Whether it is a status epilepticus.
That is why she told it's 5 minutes. So then the question is whether we are dealing with a normal seizure or are we dealing with a status epilepticus. That is the question we have to ask when we treat a seizure patient. And the management differs according to whether status or non-status. Okay. So if you get a seizure patient, you should not wait for any time to terminate seizures. Okay. Because seizure has direct effect on brain and direct effect on cardiac activity. Okay. The more the patient seizes, what is seizure? It's basically uncontrolled electrical neuronal activity in the brain, hypersynchronized neuronal activity. That means neurons are firing a lot, isn't it? Firing a lot uncontrollably. Usually there are systems in place in brain to prevent that. The brain will, whenever it crosses a limit, brain will shut it down. But seizure happens when brain cannot do that. Then the next step is brain has steps to prevent it going into status epilepticus. There are mechanisms about that. And the failure of that is what causes status epilepticus. But for that, in ideal conditions, status epilepticus is defined as any single episode of seizure which lasts more than 5 minutes or
2 episodes without regaining of
two
consciousness.
consecutive episodes of seizure without
regaining consciousness in between.
Without regaining consciousness. So this is the definition. But even though this is a definition, it shouldn't mean that we have to wait 5 minutes to see its status. Okay? Because when you wait, the more you wait, more cerebral injury is going to happen in 2 ways. One is hypoxic injury. When you are having active seizures, the oxygen demand of the brain is very high and patient's respiratory efforts will be very low. Patient can have aspiration problem causing hypoxia, and that can directly cause hypoxic brain injury. Similarly, it can also be due to hypoglycemic brain injury. Uses a lot of blood glucoses because there is a lot of tonic activity, as well as the CS of glucose will also come down because brain is using glucose. Because of these two, the more prolonged the seizure, more direct brain injury seizure will cause. This is why post-CVA patients, post-traumatic brain injury patients, when we manage those patients, there is something known as prevention of secondary brain injuries. And the prevention of secondary brain injury have 8 steps. And one of the steps is prevent seizures. Because already brain is having injury, seizure causes more injury. So even the first episode of seizure can cause injury to the brain if it is prolonged. So do not make it prolonged. You can terminate the seizure if patient is in front of you. You don't have to wait for seizure to terminate by itself. But by the time you arrange the medicines to terminate, if the seizure terminates by itself, that's well and fine. You don't have to give the medicine. You can then wait and watch. But do not take time to terminate or do not take time to evaluate the patient. Seizure should be stopped when you see. Okay? No, that is one thing. So we covered what is status, how to diagnose status, and how to manage a seizure. Seizure has to be managed. Now, how to manage seizure? What is the drug that you will give?
Benzodiazepines.
Yes, you should give a sedative that will lower the cerebral activity. One of the easiest drug that you have is a
Lorazepam.
pick up.
Lorazepam.
Benzodiazepines, diazepam, lorazepam, and midazolam, right? These are the three options. In our country, all three are commonly used everywhere. You go to a normal PHC or a secondary center, diazepam is the drug of choice, especially in children, because diazepam suppository you have. So you give suppositories. Lorazepam, very easily available. Midazolam is also there. So according to you, which is better? In an emergency viewpoint, which drug is better? Is it diazepam, lorazepam, or midazolam? Why? It doesn't matter to us now. If we give a drug like lorazepam for the patient is under lorazepam's influence for 6 hours, midazolam for 2 hours. Is it really bothering us?
Multiple routes of administration, including ASL.
Yeah. Midazolam has multiple routes of administration. You can give PR, you can give IV, IM, and intranasal. So intranasal is only available in midazolam, not in anything else. So that is one of the reasons midazolam is much more better preferred. But that is only better preferred if you have intranasal midazolam. But if you have IV, you have IV, diazepam, lorazepam, midazolam, which is better? What is your aim? To terminate the seizure fast. So what is a good drug?
Fast acting.
Fast acting drug. So it's not how long, it is how fast. Midazolam is the fastest. Diazepam is the slowest. Lorazepam is in middle and midazolam is the fastest. So it's not wrong to use any medicine. Any benzodiazepine is the correct answer. It depends what you have. You have Loraz and diazepam, Loraz is better. You have Loraz and midazolam, Midas is better. Got it? Faster acting drug is what we look for because we want to terminate faster. We don't want to prolong it. Prolonged action is not at all going to help us because we have to evaluate why the patient develops seizure. And one of the evaluation is EEG. And if you want to do a EEG, patient's brain should not be under suppression. You give diazepam, suppression is for 10 to 12 hours. So basically you do EEG unless it is status, your EEG may not show a good cerebral activity. Okay, but at the time of suppressing seizure, you don't have to worry about EEG. You should worry about what is the fastest drug you have, isn't it? Now, why you have to give benzodiazepine? It's not an anti-seizure medication, isn't it? It's a cerebral suppression medication. It's an anesthetic medication. Why not an anti-seizure medication? What are the anti-seizure medications you know? Phenytoin, phosphenitoin, levetiracetam, sodium valproate, isn't it? Why not these things? Why you give benzodiazepine?
Sedation also. Side effects.
Side effects. During seizure, are we really concerned about side effects?
These days, drugs takes time to act.
Phenytoin, phosphenitoin, levetiracetam, sodium valproate, everything is infusion. You have to take time to give. Eptoin, you have to give 15 mg 15 mg per minute is the maximum flow you can give. So 15 to 20 mg per kg of Eptoin will take around 45 to 50 minutes to get into, to complete the infusion. Fosfentoin you can give much more faster. Rather than 15 mg per kg, you can give around 25 mg per kg. That is nearly the double what we can. So instead of 45 to 50 minutes, you can finish it in 25 to 30 minutes. Levetiracetam is 30 minutes infusion. Sodium valproate is 20 minutes infusion. So 20 minutes you need to give for the drug to affect. You can't wait. That's why we give fastest drug. That's why benzodiazepines. Okay, but benzodiazepines means that as soon as the effect of benzodiazepines decrease, patient will start seizures again. Okay, so to prevent further seizures, you will have to start the patient on anti-epileptics. Okay, so termination of seizure is different and prevention of seizure is different. So termination is always benzodiazepines. Prevention is specific anti-epileptic agents. Okay, fine. So you are giving benzodiazepines. How much will you give? What is the dose of midazolam?
Lorazepam 2 milligrams we give.
2 milligrams.
0.05 to 1 milligram per kg.
Yes, 0.05 to 1 milligram.
Per kg.
0.05 to 0.1 milligram per kg we give. Similarly to midazolam, 0.05 mg to 1 mg. That will roughly come around 3 to 4 mgs it will come. It's ideal not to exceed 4 mg midazolam or 4 mg lorazepam in a single setting, because higher the benzodiazepine dose, higher the rate induced complications of benzodiazepines are. What are the rate induced quantity induced complications of benzodiazepines?
Depression will be there.
Respiratory depression?
Hypotension can be
yes,
there.
cardiac depressions. So cardiac depressions, hypotension, bradycardia is a side effect. That side effect increases the more the dose you give. So single bolus more than 4 mg should be very careful. Unless you can't resuscitate a patient, you are in a position in which you can't resuscitate a patient, you should not go for more than 4 mg midazolam or lorazepam. In a single setting, you can repeat it. In 15 minutes, you can repeat it. But in a single setting, it's a bit risky. And if at all you are giving medications like benzodiazepines or even anti-seizure medications, you should be ready to secure the airway of the patient, give fluid resuscitation to prevent hypotension, or even start inotropes for hypotension. Isn't it? Yes. So, benzodiazepine as the drug of choice. Now coming to anti-seizure medications. What are the anti-seizure medications? You know, we covered Eptoin, fosfentoin, levetiracetam, sodium valproate. Anything else? Phenobarbitons. These are the most common. What are the most commonly available anti-seizure medication? Anywhere, universally go. Phentoin. It's phenytoin. Phentoin is the most commonest. What is the dose?
Phentoin, 20 milligrams per kg.
15 to 20 mg per kg is the loading dose. Once you load the patient with this, you have to continue the same drug as oral dosing or even IV dosing to maintain the plasma drug levels. If the plasma drug level decreases, again patient can develop seizures. So once you load the patient, you have to continue the drug in a TAD or BD dosage. That is phentoin. What about fosfentoin?
Say 150 milliequivalents corresponding to 20 milligrams per kg.
Yes, 20 mg per kg is fosfentoin. Fosfentoin is basically active metabolite of phenytoin. Only thing is we can give it much faster and the same dosage. Much faster is the basic added advantage. Then levetiracetam. How much will you give?
2000 to 4000 milligrams. That means 20 to 60 milligrams.
20 to 60 milligrams. So basically it is nearly double to triple the dose of what we usually give. 15 to 20, we jump to 20 to 60 milligram per kg is what we give. Usually loading is given at 60 milligrams per kg. 50 to 60 milligrams per kg is what we usually give as loading dose. Fine. Sodium valproate? 15 to 20 mg per kg. So these are the drugs. You can use whatever anti-seizure medications you have, unless the patient has any previous recorded seizure activity, means allergic activity to it. You can use whatever you can. We normally use here Levipil because it is readily available to us. We can transfuse Levipil much more faster than Eptoin. That's the main reason why you use Levipil as such. Okay. Now, if this patient, or the patient presented to you with the history of recreational drug use, patient has taken LSD or something like that, presence with seizure, ongoing seizure, what will you give? Or should you give anti-seizure medication? You will terminate with benzodiazepines, right? There is no doubt in that. Benzodiazepines, true. Should you give Eptoin or Fosfentoin or Levetiracetam? Should you or not? No. Why? Because the insult to brain is due to a reversible agent. You treat what is causing the seizure, that is withdrawal of drug and supportive management, patient seizure will abort by itself. There is no point in giving anti-seizure medication. Similarly, seizures are one of the complications of OP poisoning. Treatment for OP-induced seizures are benzodiazepines. We don't give anti-seizure medication. Basically, poisoning-induced or overdose-induced seizures is treated with benzodiazepines rather than anti-seizure medications. Similarly, another investigation we didn't go through, if a non-case of seizure patient is presenting with seizure and is already on anti-seizure medication, we should send drug level of the seizure medication. Patient is on Eptoin drug level should be sent. Hypo and hyper levels can both cause seizures. So, sending of Eptoin drug levels are important. What are the blood investigation? Total counts, CRP, ESR to look for infections. All electrolytes to look for electrolyte abnormalities. Urea, creatinine to look for renal failure with uremia. If patient is not a non-case of CLD and first episode of seizure, you should send ammonia to look for hyperammonemia or look for ultrasound to diagnose CLD. Patient is already a non-case of CLD, you can rule out other conditions and hyperammonemia will be a diagnosis of exclusion. Yes, okay for seizure, no? Okay. Status is another huge thing. Status epilepticus is a huge topic. We'll take it on a next day. Any other status cases come, take a present, we'll clear it then. Okay.